Welcome back guys. Now in this video, let's discuss about the topic of intersex. Guys, this is a very interesting topic. Rather, I should say, this is my favorite topic. Guys, before understanding intersex, one should know the basics about how normal reproductive organs develop in a male and female embryos. Guys, I have completely discussed that topic in a different video. Okay, that is development of male and female reproductive organs and congenital anomalies. That's a totally different video. But in this video, to make the concept more clear, I'm going to touch upon that area briefly. Without any further ado, let's start with the development of male genitalia. Guys, in a male embryo, we all know that there is presence of this Y chromosome. Why? Because males are XY. Because of the presence of this Y chromosome, there is this SRY gene. And we all know that SRY gene, which is also known as a testis determining factor. See, this SRY gene is going to code for the development of testis. And we know that in this testicular tissue, there are these Sertoli cells. And these Sertoli cells are making Mullerian inhibiting factor. In the name itself, it's very clear, Mullerian inhibiting factor. So, this factor is going to inhibit the Mullerian ducts. Once the Mullerian ducts are inhibited or regressed, in a male fetus, there is no Mullerian duct derivatives. What does I mean by? So, a male fetus is going to make the Mullerian inhibiting factor, and that Mullerian inhibiting factor will cause the regression of the Mullerian ducts in a male fetus. So, Mullerian duct derivatives like uterus, fallopian tube, cervix and upper two-thirds of vagina, they are not going to develop in a male fetus. Why do male require uterus, fallopian tube, cervix and upper two-thirds of vagina? Male does not require all these structures. So these structures are not formed in a male fetus because the Mullerian ducts are regressed. Okay. Now after that, please concentrate on the next half of the slide. See, these Leydig cells are going to make a testosterone. Now this testosterone is going to act on the Wolffian duct, the male duct. Now important point is that for the expression or for the development of this Wolffian duct, it is very much important to have this functional testosterone. Only if there is testosterone, Wolffian duct will be expressed. If there is no testosterone, Wolffian duct will also undergo regression. So in this condition, this is a male fetus, it's making the testosterone. So Wolffian ducts are going to express, and the expression or the development of this Wolffian duct is going to produce male internal reproductive organs like epididymis, seminiferous tubules, prostatic urethra, vas deferens. So all these male internal reproductive organs are developed because of the expression of Wolffian duct. Okay, internal reproductive organs, okay. What about the external reproductive organs? See, some amount of this testosterone is going to convert into a more potent form of androgen, that is dihydrotestosterone. So dihydrotestosterone is being formed in a male fetus with the help of enzyme 5-alpha reductase. So testosterone getting converted into dihydrotestosterone. See, what is this dihydrotestosterone is doing? See, this dihydrotestosterone plays a very, very important role in the formation of male external genitalia. What it is doing? This dihydrotestosterone is going to act on certain embryological regions like genital, tubercle, genital swellings and genital folds. So, whenever these embryological regions, whenever they are acted upon by this dihydrotestosterone, these regions will convert into male external genitalia. So, please concentrate. There is development of glans penis, scrotum and penile urethra. All these are male external genitalia. Okay. So, this is how a male internal reproductive organs are formed and male external reproductive organs are formed. And also very clear why a male does not have uterus, fallopian tube, cervix and vagina. Why? Because the Mullerian duct in a male is inhibited by Mullerian inhibiting factor from Sertoli cells. The concept is that, for example, a male is not producing Mullerian inhibiting factor. Okay, let's take a hypothetical scenario. For example, now a male is not producing Mullerian inhibiting factor. What happens? Now in this male fetus, there is no Mullerian inhibiting factor. So the Mullerian ducts are not going to undergo regression. So they will undergo expression. They will develop. So that a male fetus can have uterus, fallopian tubes, upper two-third of vagina and cervix. Yes, it is possible. If a male is not making Mullerian inhibiting factor, then this male can develop all these structures. True. Now, one more concept is that dihydrotestosterone is converting these embryological regions into male external genitalia. For example, for some time, let's think like this. There is no dihydrotestosterone. Whenever there is no dihydrotestosterone, what happens? What happened to these embryological regions? Whenever there is no dihydrotestosterone, these embryological regions are going to convert into female external genitalia. So, there is this male fetus, and this male fetus is failed in producing the dihydrotestosterone. So, this male will develop female external genitalia, that is vulva. So, a male can have vulva, possible. A male can have uterus, possible. Okay, so all these are the concepts. Now, let's talk about development of a female genitalia. Now, there is this female embryo, and female embryo doesn't have this Y chromosome. Yes, and there is absent of this SRY gene. Now, whenever the SRY gene is absent or testis determining factor is absent, automatically the gonads will become ovaries. Now, we all know that in ovaries, Sertoli cells are not there, Leydig cells are not there. See, Sertoli and Leydig cells, they are present in the testis. So, whenever there are no Sertoli cells, there is no Mullerian inhibiting factor. Now, whenever there is no Mullerian inhibiting factor, the Mullerian ducts in a female, they are expressed. So, a female will have uterus, fallopian tubes, cervix and upper two-third of vagina. So, the Mullerian duct is getting developed in a female fetus. Now, please concentrate on the next half of the flowchart. Now, just like the Sertoli cells, Leydig cells are also not there. Whenever there are no Leydig cells, there is no testosterone. Whenever there is no testosterone, guys, this is very, very important. I have already said that for the development of Wolffian duct, you need to have a functional testosterone. Whenever there is no testosterone, what happens to the Wolffian duct in the female? Females also have this Wolffian duct. So, the Wolffian duct in a female fetus will undergo regression. So, as there is absence of this testosterone, Wolffian duct is undergoing regression in a female. Okay, well and good. What about the external genitalia development? Okay, what about the external genitalia development in a female? Guys, as there is no testosterone, do you think there will be dihydrotestosterone in a female? No. First of all, there are no Leydig cells, no testosterone. So, how can there be dihydrotestosterone? There is no dihydrotestosterone. Whenever there is no dihydrotestosterone, what happens? What I have said you. Whenever there is no dihydrotestosterone, automatically by default, the external genitalia will become a female. The basic default human genitalia is female. Okay, so it is testosterone, or I should say dihydrotestosterone, who decides the fate of genitalia. If there is dihydrotestosterone, there will be development of male genitalia. If there is no dihydrotestosterone, by default, the genitalia will become, the external genitalia will become female or vulva. Okay. Now, see, there is no dihydrotestosterone. What's happening to the external genitalia? External genitalia of a female are formed. This genital tubercle, it's now forming the clitoris. Now, genital swellings are going to form the labia majora, and genital folds, they are making the labia minora. Okay, now let me explain this concept in a bit more detail. Okay, now please concentrate on this slide, guys. See, this is an undifferentiated stage. Okay, now I am taking an undifferentiated stage, and the structures which I am showing you here, this yellow color structure is a genital tubercle. And these midline folds, okay, are these medial folds which I am highlighting right now, these are genital folds. And these swellings which are present more laterally, okay, these swellings, they are known as genital swellings. So this is an undifferentiated stage which is common for both male and female fetuses. This is an undifferentiated stage which is present in both the sexes. Now, if it is a male is going to have testis, and testis have these cells which are known as the Leydig cells. They are going to make testosterone, and testosterone is getting converted into dihydrotestosterone. And this dihydrotestosterone is going to act on this embryological structures. So what happened, guys? See, this genital tubercle, this yellow structure is going to form the glans penis. Now, this midline fold, genital folds, they are forming the penile urethra. And these swellings, okay, these lateral swellings, they will fuse, okay, they will fuse and they will form this scrotum. Okay. Now, please concentrate on the female side. Females do not have the testis, there is no testosterone and there is no dihydrotestosterone. So, the same structure is going to form the vulva in the female. So, this genital tubercle is going to form the clitoris. Now, these medial swellings, genital folds, they are going to form the labia minora. And the lateral folds, these genital swellings, okay, they are going to form the labia majora. Okay, so it's the mere presence of dihydrotestosterone determines the fate of external genitalia. Dihydrotestosterone present, male genitalia, simple absence, female genitalia. Now, if someone asks you that for the formation of female external genitalia, do you need estrogens? No, estrogens are not required for the formation of a female external genitalia. Estrogens are very much important for the formation of a breast. But for the formation of vulva, estrogens are not required. Simple absence of dihydrotestosterone, female reproductive organs. Okay, so this is the basics. Now, let's discuss about Mullerian agenesis. What exactly happening in the Mullerian agenesis, guys? In the name itself, very clear, Mullerian agenesis. So, Mullerian ducts, they are not getting developed. Where do we need development of Mullerian ducts, guys? In a female. In a female, if Mullerian ducts are not developing, means what happens? The derivatives of Mullerian ducts are not going to be formed. What are the derivatives of Mullerian ducts, guys? Mullerian ducts will form uterus, fallopian tubes, cervix and upper two-thirds of the vagina. So whenever in the case of Mullerian agenesis, whenever there is no Mullerian duct, these females are not going to have uterus, fallopian tube, cervix and upper two-thirds of vagina. Okay, so can she have normal menstrual cycles? No, this female is not going to have a normal menstrual cycles. So this female, by the age of 14-15, by the time of puberty, she is going to present in the clinic with a chief complaint of primary amenorrhea or chief complaint of not attaining the menarche. Okay, now what about the secondary sexual characters in this female of Mullerian agenesis, guys? Secondary sexual characters, are they present? Yes, they are absolutely present. Why? Because the fetal, or I should say the adrenal glands in this female, okay, the adrenal glands in this female, they are functional. They are producing the androgens, okay, weak androgens, and these androgens are responsible for the formation of pubic hair and axillary hair. So pubic hair formation, axillary hair formation normally present. And these females with Mullerian agenesis, they are not having the derivatives of Mullerian duct, but ovaries are present. Important MCQ. Ovary development in a female with Mullerian agenesis is normal. Why? Because ovaries, they are not a products of Mullerian ducts. Ovaries are derivatives of a genital ridge. Okay, so genital ridge is absolutely normal. Genital ridge is forming the ovaries, and these ovaries are functional. They are making the estrogens, and these estrogens will cause the breast development in this female. So breast development is normal, axillary hair development is normal, pubic hair development is normal. The only problem with this female is not attaining menarche. Menses are not there. Okay, so that's what the problem is. So now our female is 46XX, absolutely female, and she is having a female phenotype. Okay, what does I mean by female phenotype? She is having normal vulva. Okay, normal vulva. Why? Because this is a female. No androgens. Automatically, the default external genitalia is female. So phenotype is female. What's the problem? The problem is complete degeneration of the Mullerian ducts. So there is absence of the uterus, absence of fallopian tube, and absence of upper two-thirds of vagina. Okay, now what about the other organ system anomalies? Guys, please understand something like this. See, if Mullerian ducts are not developing, do you think that only Mullerian ducts will not develop? The surrounding regions may also not develop properly. Or for example, as I every time say, for example, imagine that there is a bomb blast. Do you think that there will be one specific area will be destroyed? No. The surroundings area will also destroy. In the same way, in this condition of Mullerian agenesis, not only Mullerian ducts will be affected, certain other embryological structures can be affected. So there can be associated renal anomalies like renal agenesis or horseshoe kidney or hemivertebrae, scoliosis, and cardiac anomalies can be seen in these females with the Mullerian agenesis. Please consider, guys, what is the chief complaint? The chief complaint is primary amenorrhea or not attaining the menarche. Now, what about the secondary sexual characters? I have already discussed that breast development, pubic hair development, and axillary hair development are absolutely normal. Now, if you do the physical examination, that's for example, the rectal examination. What can you see? Vagina is felt like a blind pouch. Why? There is a simple shallow depression. Why? Because there is only lower one-third of vagina. Why? Because the urogenital sinus is going to form the lower one-third of vagina. So what you can feel is only the lower one-third of vagina. As the Mullerian ducts are gone, there is non-development of upper two-third of vagina. So what you can feel is a blind pouch. Okay. Now, if you do ultrasonography, can you see uterus, cervix, fallopian tubes, and upper two-third of vagina? No. There is absence of uterus, fallopian tube, cervix, and upper two-third of vagina. Now, what can we do for this female? What can we do is vaginoplasty. Okay, why? Because see, she is having a simple blind pouched vagina. There is a shallow depression. Now, she cannot able to have a normal intercourse after marriage. So what we can do here is vaginoplasty. Okay, so that she can have a normal intercourse after her marriage. Now, what about her uterus, fallopian tubes, cervix? Can we do a replacement of these organs, or can we do like a transplantation of uterus? Is it possible? No, we are not going to do that. For her to become mother, there is no need of uterus because she is having intact ovaries. Ovaries are absolutely normal. If her ovaries are absolutely normal, she is going to make the ova, and we can collect this ova and we can fertilize it with the partner sperm, so that we are going to do the in vitro fertilization and we are going to transfer this embryo or this zygote into the surrogate mother. So she can have a biological child, but she is not going to have the childbearing. As there is no uterus, childbearing is not possible, but she can be a biological mother. Okay, important MCQ, that females with MRKH syndrome, okay, MRKH means Mayer-Rokitansky-Kushner-Hauser syndrome, which is simply called as Mullerian agenesis or MRKH syndrome. They can have a biological offspring because of normal ovarian function. Ovaries are there, they develop from genital ridges, not the Mullerian ducts. Okay, important MCQ. I know I am repeating because they keep on repeatedly asking the exams. Okay, now, so they should undergo for the surrogacy to have a biological offspring. Okay, now after Mullerian agenesis, let's discuss about a very interesting condition which is known as a testicular feminization syndrome, which is also known as androgen insensitivity syndrome. In the name itself, very clear that androgens are insensitive or androgens are non-functional. So, what's happening in this condition? There is this male child, male embryo, and in this male embryo there is this Y chromosome, SRY gene is present, so that there is testis. Now this testis is it's functional. Now the Sertoli cells which are present in this testis, they are making the Mullerian inhibiting factor, something normally, and this Mullerian inhibiting factor is going to cause the regression of the Mullerian ducts. Mullerian ducts are regressed. Okay. Now as the Mullerian ducts are regressed, uterus, fallopian tubes, cervix and upper vagina, they are not getting formed in a male, something normal. So this half of the slide, this part of the flowchart is something normal, and this should happen in a male embryo. Okay, male fetus, this should happen. Now what about the other half of the flowchart? This is the place where problem lies. See, the Leydig cells which are present in this testis, they are making the testosterone. Okay, well and good. Now this testosterone is a non-functional testosterone. This testosterone is unable to act on the receptors, or I should say this testosterone is unable to stimulate the testosterone receptors. So it's just simply looking like a condition where there is no testosterone. Okay, if it is unable to stimulate the receptors, then what is the use of this testosterone? It's just simply looking like there is no testosterone at all. Now, what happens with the Wolffian duct? Just tell me. Wolffian duct development needs a testosterone. If there is no testosterone, now Wolffian duct will undergo regression. If Wolffian ducts are regressed, the male internal reproductive organs, they are not going to form. So epididymis, seminal vesicles, seminiferous tubules, prostatic urethra, vas deferens, all these structures which are supposed to form in a male, now they are not developing. Okay, well and good. What about the external genitalia? See, for the development of external genitalia, you need to have conversion of a testosterone into dihydrotestosterone. See, here they are non-functional testosterone. See, whenever there is this non-functional testosterone, is not going to convert into this dihydrotestosterone also. So, if there is no dihydrotestosterone, what happens, guys? By default, okay, whenever there is no functional testosterone, by default, the external genitalia will become female. So, now in this male child, it's because of the non-functional androgens. The external genitalia, they are becoming female-like. So, a male is going to born. Okay, this male is going to born with the vulva. Okay, the labia minora, labia majora, clitoris, all these structures are going to be seen by the time of birth. So, this child was confused. This male child was confused with a female. The doctor is going to announce that you have a female child to the parents. Okay, and this baby was raised as a female. Why? Because it's very clear that external genitalia are absolutely female. So who will think that this is a male child who is having non-functional androgens, and because of the non-functional androgens, the external genitalia are becoming female-like? Who thinks like that? Just by looking at the genitalia, the doctor is going to announce to the parents that your child is a female. And now this child, who is actually a male, okay, genetically a male, is raised as a female. Now, by the time this child attains puberty, this child will have the breast development. Yes, this male child who is raised as a female will develop the breast tissue. Why? Why? Because, see, please concentrate. Does this male child have testosterone or not? Yes, testosterone is there, but it is non-functional. Now, what happens is, this testosterone in the body, all this testosterone in the body, it is getting peripherally aromatized with the help of enzyme aromatase. With the help of enzyme aromatase in the adipose tissue, All this testosterone is getting converted into estrogens. Now there are lots and lots of peripheral aromatization happening. All the testosterone is getting converted into estrogens. So there is high levels of estrogens, and this high level of estrogen will cause the breast development in this child. Okay, a male child raised as a female, and this male child who is raised as a female is now developing the breast. Breast is there. The external genitalia is absolutely female-like. But what about the menses? Now, does this male child who is raised as a female, does she have menses? No, there is no menarche. Why there is no menarche? Why? Because there is absence of uterus, fallopian tubes, cervix and upper vagina. Okay, see, there are these testes in this female. Okay, testes are present intra-abdominally. Okay, so testes are present intra-abdominally, and this testis is producing the Mullerian inhibiting factor, and this Mullerian inhibiting factor during the embryological life have caused the regression of the Mullerian ducts. So there is no uterus, no fallopian tubes, no cervix and no upper two-thirds of the vagina. So there is no menses. As there is no uterus, no menarche, but breast development is there. Okay, now the question is, what about the secondary sexual characters like axillary hair development and pubic hair development? Guys, this is the area which is very important, because from here you will get a question. Now guys, please concentrate that the axillary hair development and pubic hair development, they are testosterone dependent or androgen dependent. Now in this female child, there is this testosterone, but it is non-functional testosterone. It is unable to stimulate its receptors. Now, do you think that this child will have the development of axillary hair and pubic hair? No, axillary hair development and pubic hair development is not there. Okay, because of a non-functional testosterone. So this is a very important point. Breast development is present. The external genitalia is absolutely female-like, but the secondary sexual characters are not developed. Okay, and the female is going to present to your clinic with a chief complaint of amenorrhea, primary amenorrhea. Okay, now let's continue our topic. Now, testicular feminization syndrome is a condition where the karyotype is 46XY, which means it's a male. Okay, genetically it's a male. Now, what about the phenotype? Phenotype is all about the external genitalia. Okay, external genitalia is looking absolutely like a female. Okay. Now, what about the bar body? Guys, bar body is something which is present in a female fetus. Okay, out of 2 X chromosomes, 1 X chromosome will undergo lionization or inactivation. So, a bar body is something which is present in a female child, but this is a male child looking like a female. So, bar body is absent. Okay. See, this testicular feminization syndrome is also known as androgen insensitivity syndrome. We have already discussed that. Now, what are the clinical features? The female is going to have a primary amenorrhea because of the absence of uterus, cervix, okay, and fallopian tubes. Normal breast development is there, okay, because of the peripheral aromatization. Now, underdeveloped or absence of the pubic and axillary hair. Okay, secondary sexual characters are not developed because of non-functional testosterones. Okay, guys, this is a very important MCQ. See, these females who are actually males, these females are going to present to the clinic with a chief complaint of primary amenorrhea, but they can also present in your clinic with a complaint of inguinal hernia. Why? See, this inguinal hernia is nothing but the undescended testis which got blocked in the inguinal canal. Guys, see, testis, okay, like in intrauterine life, they are intra-abdominal organs. Okay, testis are formed in the abdomen. We all know that the testosterone will act on the gubernaculum testis. So there will be descent of this testis into scrotum. Important point, sir. Descent of testis into scrotum is done by gubernaculum testis. And for this descent, testosterone is must. Now in this condition, testes are formed, true. But the testosterone which is inactive, or the testosterone which is non-functional, is not acting on the gubernaculum testis. So the descent of testis is not happening into the scrotum. So now these testes are left inside the abdomen, or sometimes these testes will find in the inguinal canal, leading to inguinal hernia. So inguinal hernia is due to undescended testis. Okay. So what are the laboratory findings, guys? Laboratory findings may show high to normal levels of testosterone. What are the ultrasonographic findings? If you do ultrasonography in this female who is actually male, I am repeating, okay, every time it's genetically a male but looking like a female, okay, so we are not sure whether to call this a male or a female, okay. Now, ultrasonographic findings show absence of uterus, absence of fallopian tubes and cervix. And sometimes you may find intra-abdominal testis. Sometimes they might be also present in the inguinal canal, or sometimes you may also find these testes under the labia. Okay, so the external genitalia, labia, under the labia you might also find these swellings. These swellings are nothing but the testes which are undescended. Okay, now after this, what can we do for these females of testicular feminization syndrome? Guys, what you can do is a vaginoplasty. Why vaginoplasty? Why? Because see, there are no Mullerian ducts. First of all, there are no Mullerian ducts. Mullerian ducts got completely regressed. So the upper two-thirds of vagina, which are derivative of Mullerian duct, they are not there. So there is only shallow vagina. There is only shallow blind pouch vagina. There is only shallow dimpling. So with this shallow vagina, she cannot participate in the intercourse. So what you can offer her is vaginoplasty. Okay. So just before marriage, you can do vaginoplasty MCQ. Okay. After this, what about the testis in this female? Okay. The testis, the intra-abdominal organs, what can you do with this testis? Should you have to remove them? Yes, you should remove them. Why? Because these intra-abdominal testes, they are at a risk of developing a malignancy. That is like a gonadoblastoma benign stage and dysgerminoma. So this intra-abdominal testis should be removed. But when they should be removed? See, you have to remove them only after attainment of puberty. Okay, please concentrate. The testis should be removed only after puberty. Why only after puberty? Why not before puberty, somewhere around 10 or 8 years? Why not? Or why not immediately after like delivery, if the diagnosis of testicular feminization syndrome is confirmed? Why not before puberty? Why? Because see, these testes which are intra-abdominal, they are the only source of estrogens. This testis is forming the testosterone, and this testosterone is getting converted into estrogens, and now these estrogens are the only one which cause the breast development in this female. So if you take out this testis, you are just simply knocking out the production of testosterone, and there is no estrogens at all. If there is no estrogens, there is no breast development. So before puberty, if you take out the testis, means you are taking out the source of estrogens. Now she won't develop the breast. So in order to have the breast development, you have to remove this testis only after the attainment of puberty. After the breast is completely formed, you can take out this testis to prevent the malignancy. So intra-abdominal testis should be removed as there is a risk of a gonadoblastoma and dysgeminoma. Okay. Now, see, these females should be kept on hormone replacement therapy to prevent the osteoporosis. Why? Why? Because you have taken out this intra-abdominal testis. Now, if you take out this testis, you have removed the source for the estrogens. You have taken out the source of estrogens. Whenever there are no estrogens, we all know that the osteoclasts in this female body, okay, the osteoclasts in these bones, they will be activated and they will cause like too much amount of bone resorption. That will cause osteoporosis. So to prevent osteoporosis, what you can do is hormone replacement therapy. You should replace the estrogens. So to prevent the bones from osteoporosis. So estrogen replacement therapy is given. Okay. Now, guys, important points are the female with the testicular feminization syndrome is actually a male. A female with testicular feminization syndrome will have normal breast development, but the secondary sexual characters like axillary hair development and pubic hair development are absent. Okay. Now, after this, please concentrate the main important differences between the MRKH syndrome, that is Mullerian agenesis, and androgen insensitivity syndrome. Guys, this slide is very, very important. If you want to answer a clinical question, you should know this table very good. Okay. Now, the phenotype in MRKH is 46XX, which means something normal female. Now, what about the AS, guys? It is 46XY. Okay, there is Y chromosome. It's actually a male. Now, what about the gonads? The gonads here in this MRKH are ovaries, and the gonads in androgen insensitivity syndrome is they are testes. Now, what's the chief complaint, guys? Guys, this is very, very important. Both the conditions are going to present to the clinic with a chief complaint of primary amenorrhea. Both the conditions are going to present with the primary amenorrhea. Okay, both they will say, doctor, we are not having the menses. Okay, now what about the external genitalia, guys? External genitalia is vulva. Here also vulva. What about the vagina, guys? If you have performed the digital rectal examination, the vagina is shallow here, even shallow here. Both the conditions are shallow. Now, what about the secondary sexual characters, guys? Important MCQ. In MRKH syndrome, the secondary sexual characters are developed. Okay. But in androgen insensitivity syndrome, as the testosterone is a non-functional, the secondary sexual characters like axillary hair development and pubic hair development is undeveloped or underdeveloped. Okay. Now, what about the breast development? In MRKH syndrome, the breasts are absolutely normal, they are developed, and even in androgen insensitivity syndrome, the breasts are developed, and even you have a bigger size breast. Okay, Tanner size breast 4, Tanner size 4. See, breast development is something normal, but a child of 14-15-year-old having a Tanner size 4 breast is something not normal. Lots and lots of peripheral aromatization happening in the condition of androgen insensitivity syndrome. So all the testosterone is getting converted into estrogens, and these estrogens are making a bigger breast. Okay. Now, what about the ultrasonographic findings? See, if you have performed ultrasonography, the uterus, cervix, fallopian tubes all are absent. Okay. And here also uterus, cervix, fallopian tubes are absent here. In MRKH, it's because of the Mullerian agenesis, all the Mullerian derivatives are not formed. And in androgen insensitivity syndrome, there is this Y chromosome. Because of the Y chromosome, there is this testis, and in the testis there are these serotolin cells, and these serotolin cells are making Mullerian inhibiting factor, and that Mullerian inhibiting factor is going to cause regression of the Mullerian ducts. So Mullerian derivatives like uterus, cervix, fallopian tubes are absent. Now, guys, this is a very, very important area. That's the testosterone. Guys, in MRKH syndrome, this is a normal female. Okay, normal female. Now, in a normal female, there will be normal female range androgens. Okay, 20 to 80 nanograms per deciliter. This is a normal female range testosterone. But see, the condition of androgen insensitivity syndrome, the androgen levels are male range. Okay, this is a male, right? So, male range testosterones will be present in the condition of androgen insensitivity syndrome. Okay, so these are the major differences between the two. Now, after this, let's see some clinical cases. Okay, there is this 15-year-old girl who was brought to the OPD with the chief complaint of primary amenorrhea. If I am saying primary amenorrhea, even the MRKH patients and androgen insensitivity patients, both of them are going to present with the primary amenorrhea. First thing. Now, there is no history of cyclical abdominal pain. See, this word cyclical abdominal pain should remind you about a condition known as a cryptomenorrhea. Okay, see, cyclical abdominal pain means every month she is having this abdominal pain, and this abdominal pain may be because of the hidden menstruation. See, if she is having transverse vaginal septum, or if she is having imperforate hymen, now she is not having menses outside, but inside she is having all these things. Okay, normal menstrual cycle is going on, but they are not coming out. This menstrual blood is not coming out. So now in our females, there is no history of cyclical abdominal pain, which means I can exclude these things like cryptomenorrhea. Okay. Now on examination, breast development was normal. Secondary sexual characters are normal. Breast development is there. Okay. Secondary sexual characters are normal. That is pubic hair development and axillary hair development. But uterus, cervix are not felt on per rectal examination. What is the next step in the investigation? What you should do? Now this is our female with the complaint of primary amenorrhea. Now what we should do? Here there is a sentence: uterus and cervix are not felt on per rectal examination. Now guys, please try to answer the questions based on the given information and the given options. So within the given options, you should choose a better option. Now, you should do karyotyping or not, or you should do gonadotropin levels, or you should check pelvic organs by pelvic ultrasound or MRI. The best option which you can do here is pelvic ultrasound. Why? Because see, uterus and cervix are not felt on per rectal examination. You have done the physical examination which are not felt. So now let's confirm that uterus and cervix are not present. We have to confirm them first by pelvic ultrasound. Most of the guys will think, let's go for the karyotyping. No, you are not supposed to do the karyotyping. Why? Because karyotyping takes a lot of time and it's a very expensive thing. So doing ultrasound, it's a matter of hours. Okay, it's a matter of hours. Within hours, you can know that this female is having this internal reproductive organs or not. If internal reproductive organs are not there, then you can go for the further studies like karyotyping and all. But now, within a matter of time, very easily you can know that the internal reproductive organs are present or not. So the better option you can go for is pelvic ultrasound. Okay. Now, guys, let's see this question. Same question in a different way. A 15-year-old girl was brought to the OPD with the chief complaint of primary amenorrhea. Yes, same information. No history of cyclical abdominal pain, which means I can exclude the cryptomenorrhea and all. Examination shows uterus and cervix are absent. Now it's very clearly said uterus, cervix are absent. What is the next step in the investigation? Guys, now I am getting a doubt here. See, primary amenorrhea. Okay, primary amenorrhea is there. Uterus, cervix, not there. Okay, primary amenorrhea, uterus and cervix are not there. Now, in the condition of Mullerian agenesis, this female with Mullerian agenesis is going to present to the clinic with primary amenorrhea. If you do ultrasonography, in ultrasonography, uterus, cervix, upper two-thirds of vagina, fallopian tube, all these structures are absent in Mullerian agenesis too. But also in androgen insensitivity syndrome, uterus, cervix and upper two-thirds of vagina is also absent. Now, how to differentiate between these two? Okay, how can I simply differentiate between these two conditions? How means? Should I have to go for the karyotyping? Yes. Karyotype will differentiate between androgen insensitivity syndrome and Mullerian agenesis. But karyotyping is a time taking and it is also expensive. So now the next best step is not karyotype. Karyotypy can differentiate MRKH with the Mullerian agenesis. Mullerian agenesis is 46XX and androgen insensitivity syndrome is 46X5. It can differentiate, but not now. Okay. Now, gonadotropin levels, not much information you will get with the gonadotropin levels. Now, serum testosterone. Yes, serum testosterone you can go for. Why? Why? Because, see, if it is MRKH, the testosterone levels will be of male range. Sorry, not male range, female range. That is 20 to 80 nanograms per deciliter. Okay, if it is MRKH, less amount of testosterone will be there. But if it is androgen insensitivity syndrome, where you will have 200 to 800 nanograms per deciliter. So now it's very simple, right? It's just a laboratory test. Okay, we will get the results within hours. So serum testosterone is the next best step in investigation. Now, if you are getting lots and lots of testosterone, now you can order for the karyotype. Okay, later. But now the best investigation is serum testosterone. Okay. Now, after this, let's see this question. A 15-year-old girl was brought to the OPD with the chief complaint of again primary amenorrhea, no history of cyclical abdominal pain. Examination shows the uterus and cervix are absent. What is the next step in investigation? Okay, now please see the options. Karyotyping, gonadotropin levels, pelvic ultrasound, MRI. See, what we will do with the MRI? MRI doesn't give you much information. Like, already it's very clear that uterus, cervix, they are not there. After doing MRI, much information you are not going to get. Pelvic ultrasound, same. It's already clearly given that uterus, cervix are not there. So, what you will get with the pelvic ultrasound? Gonadotropin levels, I have already said, much information you won't get. So, now, according to the given options, the best will be karyotyping. See, here testosterone levels is not there in the options. So that's the reason why I am choosing the karyotyping. Okay. So based on the given options, you should change your best answer. Okay. So these are some important clinical cases regarding MRKH syndrome and androgen insensitivity syndrome. How to differentiate between these two cases? Both the cases are primary amenorrhea. Both are the cases of primary amenorrhea. Both of them doesn't have internal reproductive organs. Okay, but one is a male, other is a female. Okay, so these are how to differentiate between these two conditions. Now let's talk about the Swyer syndrome. Guys, from now we are going to discuss about a topic known as gonadal dysgenesis. Okay, now please concentrate. That Swyer syndrome is an example of gonadal dysgenesis. So what exactly happening in this condition of gonadal dysgenesis, guys? See, we are going to take a male embryo, which means like this Swyer syndrome is going to happen for the male child. Now, in this male embryo, there is this Y chromosome present, and because of this Y chromosome, there is development of the testicular tissue. But what is the name of the topic, guys? Gonadal dysgenesis. The gonads are dysgenetic, which means the gonads are non-functional gonads. So this testis is a non-functional. Now if it is non-functional, the Sertoli cells are also non-functional. If Sertoli cells are not functional, means the Mullerian inhibiting factor is not getting produced. If Mullerian inhibiting factor is not produced in a male fetus, means what happens? Now these Mullerian ducts are going to express in a male fetus. So Mullerian ducts are getting expressed. So the derivatives of the Mullerian ducts are going to be seen in this male child. So a male child is going to develop uterus, fallopian tubes, cervix and upper vagina. So a male is developing the internal female reproductive organs. Yes. Now let's come to the other half of the flowchart. Now as the testis is non-functional in nature, the Leydig cells are also not functional. If Leydig cells are not functional, they are not going to make the testosterone. If there are no testosterone in this male, what happens? Usually, Wolffian duct need testosterone for its expression. Whenever testosterone is not there, Wolffian duct will undergo regression. If Wolffian duct undergo regression, the male internal genitalia or the male internal reproductive organs are not developed. What about the external genitalia? We all know that basic human genitalia is female-like. For the conversion of female genitalia into male genitalia, you need to have testosterone. Now, in this condition, testosterone is there? No, testosterone is not there. So, automatically, by default, the external genitalia will become female. So, this male is having internal female reproductive organs, okay, and also female external genitalia. So, anyone think that this is a male child or female child? everyone will think that by the time of birth, this is a female child and raised as a female child. But in fact, it is genotypically and karyotypically, this is a male child with female internal and external genitalia. Okay, now let's see the important differences between MRKH, AIS and Swyer syndrome. We have already discussed the differences between MRKH and AIS. Now let's see one by one important points about the Swyer syndrome. Swyer syndrome, phenotypically, it's a female. Why? Because it's having external female genitalia because of the absence of testosterone. Karyotype is 46XY. Okay, there is Y chromosome. Actually, it's a male. Now, the gonads are testis. Yes, testes are there, but they are non-functional, dysgenetic, gonadal dysgenesis. Now, what is the chief complaint? Again, primary amenorrhea. Okay, so these females are also going to come to the clinic with the chief complaint of primary amenorrhea. Why primary amenorrhea, guys? You might ask me that Swyer syndrome is a condition where there is uterus, fallopian tube, cervix, and upper vagina. So, she can have a normal menses? No. See, in order to have a normal menstrual cycle, simple presence of uterus, fallopian tube, cervix is not enough. She also need to have the ovaries. But this is a male child. Ovaries are not there. If ovaries are not there, do you think that this female is going to have normal menses? No. So, she is going to have primary amenorrhea. Okay, see, all these three conditions are going to present with the primary amenorrhea. So that's why it's very important to differentiate between MRKH, AIS and Swyer syndrome. Now, what about the external genitalia, guys? In all these conditions, the external genitalia is vulva. Okay, that is a female form. Now, what about the vagina, guys? The vagina here is normal. Why vagina is normal, guys? Okay, the lower one third. Okay, the lower one third of vagina, which is coming from the urogenital sinus, is normally coming. But the upper two third of vagina, which is a derivative of Mullerian duct, is also normal in the Swyer syndrome. Why? Because Swyer syndrome is a condition, please concentrate. Swyer syndrome is a condition where the Mullerian ducts are developed normally. So, the upper vagina, okay, the upper vagina is normally developed. Because of the absence of testosterone, the lower one third of vagina is also normally developed from the urogenital sinus. So, the vagina in a female with Swyer syndrome is normal. What about the secondary sexual characters, guys? The secondary sexual characters are undeveloped. Why undeveloped? Why? Because, see, Swyer syndrome is a condition with dysgenetic gonads. If the gonads are dysgenetic, the testosterone production is not there. If testosterone is not there, means the pubic hair and axillary hair development is not there. So, pubic and axillary hair development is undeveloped. What about the breast? Guys, here very important. See, Mullerian agenesis, MRKH is a syndrome where the breast is normally developed. AIS is a condition where there are larger breasts. But what about the Swyer syndrome? Swyer syndrome, even the breasts are not developed. Why? She is having primary amenorrhea, and also breasts are undeveloped. Why breasts are undeveloped? Why? Because there are no ovaries. First of all, in this condition, testosterone is not there. If testosterone is not there, there is no possibility for the peripheral aromatization. At least, remember, at least in AIS, testosterone is there. Though it is a non-functional, testosterone is there in AIS. And it is peripherally getting aromatized to estrogens. And because of that estrogens, now a female with androgen insensitivity syndrome, now she is having the bigger breast. But here in Swyer syndrome, because of dysgenetic gonads, there are no testosterone. Whenever there is no testosterone, there is no peripheral aromatization. Whenever there is no peripheral aromatization, there is no chance of estrogens and breast development is underdeveloped or undeveloped. Okay. Now, what about the ultrasonographic findings, guys? Guys, very, very important. Mullerian agenesis or MRKH, uterus, cervix, fallopian tubes are absent. Androgen insensitivity syndrome, again here also uterus, cervix, fallopian tubes are absent. But what about the Swyer syndrome? Swyer syndrome, Mullerian duct is expressed. So uterus, cervix, fallopian tubes are present. Okay, so this is all about the Swyer syndrome. Now, what you can do here, guys, important points about the Swyer syndrome are also like just like the androgen insensitivity syndrome. Even here in Swyer syndrome, the testes are intra-abdominal and they are at a risk of developing gonadoblastoma and dysgenesis. So, for a Swyer syndrome patient, you need to do prophylactic gonadectomy. Okay, that gonad should be removed. Why? Because if those gonads are intra-abdominal, they will develop the malignancy. Okay. Second thing, you need to give estrogens for her to develop the breast. Okay, she also need to be kept on hormone replacement therapy so that she won't be developing the osteoporosis. Okay, so this is all about the Swyer syndrome. Now, after Swyer syndrome, let's talk about the Turner syndrome, which is also a type of gonadal dysgenesis. Guys, what exactly is gonadal dysgenesis? Gonadal dysgenesis is a condition where the gonads are not functional, right? Even in Turner syndrome, we all know the gonads. Okay, Turner syndrome is something happening in a female. Even in Turner syndrome, the gonads are dysgenetic. So the ovaries are just like a sliver of tissue. Okay, the streak gonads, we used to call that streak gonads. So Turner syndrome is a type of gonadal dysgenesis. Now, what's the most common karyotype of Turner, guys? The most common karyotype is 46XO. That is monosomy X, which means one X chromosome is missing. Okay, one X is lost. So the missing X is mostly paternal in origin. Okay, see what actually should happen. If it is a female, XX, one X should be from the mother and one X should be from the father. What's happening here? The sperm is missing one X. Okay, sperm is not carrying one X, so it became X0. So missing X is mostly paternal in nature. And the important point is that there is no increased risk of Turner syndrome with increased maternal age. We used to say with increased maternal age there is risk of Down syndrome and other trisomies. But here, with increase in maternal age, there is no risk of Turner syndrome. Okay, important point. Now, this is the image they will give you in the exam and they will ask you, this karyotype is showing which disease. Guys, please concentrate that there is only one X chromosome and the other X chromosome is absent. So, it is a 45X0. Okay, now, guys, the most common cause of primary amenorrhea is direct single-line questions. The most common cause of primary amenorrhea is gonadal dysgenesis. And which type of gonadal dysgenesis, guys? Turner syndrome. Okay, it means the ovaries are non-functional. If the ovaries are non-functional, then how can you have the menses? See, it's the ovarian cycle which will override the uterine cycle. What does I mean by ovarian events are going to bring the changes in the uterine events. If ovaries are not functional, then the endometrial proliferation and endometrial shedding in the uterus is not going to happen. So, non-functional gonads are going to cause primary amenorrhea. So, out of all the causes of primary amenorrhea, the most common cause is gonadal dysgenesis. And which type of gonadal dysgenesis? The Turner syndrome, where the ovaries are non-functional because of the monosomy X. A complete female is because of the 2X. If there is only one X, that causes gonadal dysgenesis. Okay, now Turner is a condition of, Turner syndrome is a condition of hypergonadotropic hypogonadism. What does I mean by? Turner is a condition where there is hypogonadism, which means the gonads are hypo. What does I mean by? Hypogonadism means the ovaries are non-functional. Am I true or not? Yes. The ovaries are non-functional. If ovaries are non-functional means they are not making the estrogens. Okay, estrogens are very much low. Whenever there are no estrogens, the hypothalamo-pituitary ovarian axis, what it will think that estrogens are not there. So what the pituitary is going to do? Pituitary is going to release lots and lots of FSH, okay, in order to stimulate the ovaries. See, ovaries usually have to produce the estrogens. Now, in this condition of Turner syndrome, ovaries are non-functional. So, estrogens are not there. If estrogens are not there, the pituitary gland is trying to produce these estrogens at any cost. So, it is producing lots and lots of FSH in order to stimulate these ovaries so that the ovaries will make the estrogens. But the ovaries are not functional. So, that's the reason why we are calling this condition as hypergonadotropic. Means gonadotropic hormones are very much higher. What is that gonadotropic hormone? Nothing but the FSH. Hypergonadotropic, hypogonadism, which means the gonads are non-functional, hypogonads. Okay, so very important MCQ. Turner is a condition of hypergonadotropic hypogonadism. Now, please concentrate. All these are the clinical features in a female with Turner syndrome. Let's see one by one. Guys, please concentrate that having two X chromosomes will make a complete female. If one X chromosome is lost, then that female who is going to have is going to be half female. So, please concentrate. If two X chromosomes are there, normal height will be there. If only one X chromosome is there, the female will be short. Okay, short statured. Important MCQ. The female will be short statured when compared to a normal female. She is short statured. Now, complete female 2X. Normal breast development will be there. Now, this female is going to have shield-like chest. Okay, with widely spaced nipples. Okay, widely spaced nipples. Shield-like chest will be there. And now, if you concentrate on this area, okay, neck area, there will be webbing of the neck. Okay, webbing of the neck, and these females, these Turner females will have low posterior hairline. Okay, the hairline will be much lower. See, Turner females, you can say that the female is having Turner syndrome just by looking. Why? Because there are lots and lots of morphological features which will give you signs that this female is a Turner female. They are short stature, webbing neck will be there, widely spaced nipples, broad shield-like chest will be there. Okay, now she can have a horseshoe kidney. Please concentrate. The ovaries are dysgenetic, rudimentary ovaries, which means gonadal dysgenesis, non-functional. So there are streaky ovaries. Okay, streak ovaries will be there. Now, these females are also associated with certain cardiac anomalies like bicuspid aortic valve (MCQ). Okay, so they can have this bicuspid aortic valve and also coarctation of aorta. But most common is bicuspid aortic valve is most common. Okay, most common cardiac anomaly which is seen with the Turners is bicuspid aortic valve. They may also have coarctation of aorta. See, they have skeletal abnormalities like cubitus valgus. Okay, see the elbows are more outward. Okay, cubitus valgus will be there, and the fourth metacarpal is short. Okay, these are the features of a Turner syndrome. Important MCQ is these Turner females, most of the time they will have a normal intelligence. IQ will be normal. These are the very important points to know about the Turner female. During infancy, okay, the female just born. Okay, this Turner female, she just born. At the time of her birth, she might also present with this cystic hygroma. Okay, cystic hygroma. Okay, she may also have this cystic hygroma on her neck, and that in the later life will present as the webbing neck. Okay, webbed neck. So these are all the features, clinical features of the Turner female who have this gonadal dysgenesis. Now, after this, let's see some important points about why a Turner female is a short. Okay, see, there is a lot of information. This I have taken from an article, but few important points which you need to know are, see, on the X chromosome, there is a region known as PAR1. Okay, pseudo autosomal region 1. Now this PAR1 is present on the short arm of X chromosome. Now in this region there is a gene called as SHOX gene, okay, short stature home box containing gene. This PAR1 region is there, and in this region of the X chromosome there is a gene called SHOX gene. Okay, now this SHOX gene is very important because it is expressed in the limbs, pharyngeal arches, osteogenic cells and bone marrow, and this is very much important in the development of skeletal growth. Okay, it's very much important in the formation of the skeleton. Now because of the loss of X chromosome, this SHOX gene is also lost. If you lose this SHOX gene, you will have skeletal abnormalities. So your skeleton may be a short-statured skeleton. So the reason why Turner female is short is because of the SHOX gene loss on the X chromosome. See, X chromosome itself is lost. So SHOX gene is lost. So that's the reason why the female is a short-statured and she have this cubitus valgus and short fourth metacarpal, and all this stuff is because of loss of that SHOX gene. Okay, so we have discussed all the important points about the Swyer syndrome and Turner syndrome. Both are the examples for the gonadal dysgenesis. Now after seeing why a Turner female is short, now let's discuss other conditions of intersex. The condition which we are going to discuss is a congenital adrenal hyperplasia. It's an autosomal recessive disorder where a karyotypically female, okay, karyotypically she is a female but looks like a male. Phenotypically it looks like this female phenotypically looks like a male. Okay, so let's see why a female looks like a male. We have seen conditions where a male is looking like a female, like androgen insensitivity syndrome, Swyer syndrome. Androgen insensitivity syndrome, Swyer syndrome, these two conditions are examples of a male looking like a female. Now this congenital adrenal hyperplasia is a condition where a female looks like a male. Okay, let's see. Guys, this slide is totally depicting the steroidogenesis, okay, or corticosteroid production in the adrenal gland. Okay, see, this flowchart is entirely depicting different hormone production like aldosterone, cortisol and dihydroxytestosterone, estradiol. See, all these hormones are getting produced in the adrenal glands. This slide is a bit complex. Okay, now I will explain this topic of congenital adrenal hyperplasia in a simple way. But before that, why exactly congenital adrenal hyperplasia is happening? Why? Because there is a deficiency of certain enzymes. Deficiency of 21 hydroxylase is the most common MCQ. The most common enzyme deficiency for developing congenital adrenal hyperplasia is 21 hydroxylase deficiency. But also deficiency of 11 hydroxylase, 11 beta hydroxylase and 3 beta hydroxysteroid dehydrogenase, 17 alpha hydroxylase deficiency can also cause different forms of congenital adrenal hyperplasia. But most common enzyme deficiency is 21 hydroxylase deficiency. Okay, now let's explain the entire thing in a simple way. Okay, please concentrate. That hypothalamus is going to produce a hormone called corticotropic releasing hormone. So hypothalamus is producing CRH. This corticotropic releasing hormone, it is coming to the anterior pituitary and stimulate the corticotropes in the anterior pituitary. Now the corticotropes in the anterior pituitary are going to release the ACTH, adrenocorticotropic hormone. ACTH is getting produced. Now what this ACTH is doing? This ACTH is acting on the adrenal gland, and the adrenal gland, whenever it is acted upon by ACTH, the cholesterol in the adrenal gland is converted into pregnenolone. Okay, cholesterol is getting converted into pregnenolone, and this pregnenolone, it will be converted into 17-hydroxyprogesterone. Now this 17-hydroxyprogesterone, it will go into 3 different pathways. What are three different pathways, guys? The 17-hydroxyprogesterone, it can be converted into aldosterone, it can be converted into cortisol, and it can be converted into androgens. Okay, there are three pathways into which this 17-hydroxyprogesterone can go. Important point is that the main aim of this ACTH is not aldosterone production or not the androgen production. The reason why ACTH is there is for the production of cortisol. The main aim of ACTH is the cortisol production. So what happens? ACTH came, at the end cortisol is there. Now what this cortisol is doing? This cortisol will give the negative feedback for the ACTH, saying that enough cortisol is there, there is no need of ACTH again. So this cortisol is giving the negative feedback to the pituitary gland, so that pituitary gland will decrease the ACTH production. This is something normal. But what's happening in congenital adrenal hyperplasia? Very simple. Please concentrate here. In congenital adrenal hyperplasia, this 21-hydroxylase enzyme is not there and 11-hydroxylase enzyme is not there. So what happens? Important, remember, see, for the production of aldosterone and cortisol, remember, for the production of aldosterone and cortisol, you need to have 21-hydroxylase and 11-hydroxylase. Okay, these two enzymes are needed for the production of aldosterone and cortisol. Whenever these enzymes are not present in the condition of congenital adrenal hyperplasia, aldosterone cannot be produced, cortisol cannot be produced. So cortisol is not there. That's the main important thing. Whenever cortisol is not there, what happens? The negative feedback to the anterior pituitary is lost. So there is no negative feedback. Whenever there is no negative feedback, the anterior pituitary is going to produce lots of ACTH, and this lots of ACTH is going to stimulate the adrenal gland. So what happens? Adrenal gland is stimulated, more stimulation. So there is adrenal hyperplasia. So why there is adrenal hyperplasia, guys? This adrenal hyperplasia is because of excessive stimulation by the ACTH. Why there is excessive ACTH? Because there is no cortisol, no negative feedback. So now what's happening? When the adrenal gland is so much stimulated, the cholesterol in the adrenal gland is so much getting converted into pregnenolone. There is too much amount of pregnenolone, and all that pregnenolone is getting converted into 17-hydroxyprogesterone. So now there is lots and lots of 17-hydroxyprogesterone. Now my question is, can this 17-hydroxyprogesterone go into pathway of aldosterone? No, the 17-hydroxyprogesterone cannot go into the pathway of aldosterone. Why? Because there is no 21-hydroxylase or 11-hydroxylase. Okay, so there is, because of the deficiency of these enzymes, aldosterone cannot be formed. In the same way, these two enzymes are also needed for the formation of cortisol. So even cortisol is not getting produced. So all this 17-hydroxyprogesterone is now shunted towards the production of the androgens. All this 17-hydroxyprogesterone is now going into the pathway of androgens. So totally all this 17-hydroxyprogesterone is used for the production of androgens. So there are lots and lots of androgens in this condition. Okay, now what happens? All these androgens are going to cause virilization. Here you need to understand. Guys, for example, if congenital adrenal hyperplasia is happening in a male child, for example, there is a male fetus, and in this male fetus, there is deficiency of this 21-hydroxylase and 11-hydroxylase. In the male fetus, there will be too much amount of androgens. Then that won't be a bigger issue. Okay, it won't be a bigger problem if male have too much amount of this adrenal androgens. Why? Because males anyway have these androgens. But the problem is with the female fetus. See, if a female fetus, if she have this congenital adrenal hyperplasia, all that 17-hydroxyprogesterone is used for the formation of androgens. And now this excessive androgen levels during her infancy will, what it will do, these androgens will convert the external genitalia into male like. We have already discussed, right? If there is androgens during intrauterine life or embryonal life, the embryological structures are going to convert into male external genitalia. So now in this condition we are having excessive amount of androgens, and because of this excessive amount of androgens, now this female will undergo virilization, which means her clitoris, her clitoris is going to increase in size, causing clitoromegaly. And this clitoromegaly will look like a small penis. That is the reason why this female child will look like a male, because of this clitoromegaly. It will something look like ambiguous genitalia. It won't look like a complete male genitalia. Because of this excessive androgens, there will be fusion of the labia. There will be a fusion of labia majora. So labia majora, they will be partially fused, which just looks like a scrotum. And the clitoris will enlarge, which just looks like a small penis. So that's the reason why this female will look like a male. So there will be development of ambiguous genitalia. So congenital adrenal hyperplasia is a condition of ambiguous genitalia. Now guys, important MCQ is that what are the levels of 17-hydroxyprogesterone in congenital adrenal hyperplasia? In the condition of congenital adrenal hyperplasia, the 17-hydroxyprogesterone levels are elevated. We have already discussed, because of the excessive stimulation by the ACTH, the adrenal gland, all the cholesterol is getting converted into 17-hydroxyprogesterone, and all this 17-hydroxyprogesterone will be getting converted into androgens. So what about the levels of 17-hydroxyprogesterone? Elevated. See, if you are trying to do the screening for the congenital adrenal hyperplasia, you are suspecting that this baby is having congenital adrenal hyperplasia or not, then what you will do is you can measure the 17-hydroxyprogesterone levels. Why? Because if it is a condition of CAH, the 17-hydroxyprogesterone levels are so high. If the 17-hydroxyprogesterone levels are less than 200 nanograms per deciliter, you no need to think about CAH. See, CAH diagnosis is excluded. Why? Because if it is a CAH, there will be lots and lots of 17-hydroxyprogesterone. And if the range is between 200 to 800 nanograms per deciliter, then you can go for ACTH stimulation test. But if the 17-hydroxyprogesterone levels are more than 800 nanograms per deciliter, it is very clear that this is a condition of a congenital adrenal hyperplasia. So, at the end, I just want you to remember one point, that is, congenital adrenal hyperplasia is a condition where there is increased levels of 17-hydroxyprogesterone. Now, please concentrate on this slide. We have discussed everything. Now, let's see what's exactly happening in the congenital adrenal hyperplasia. See, if there is a deficiency of this enzyme 21-hydroxylase, I have already discussed that 21-hydroxylase is an enzyme which is needed both for the production of aldosterone and cortisol. Whenever there is no 21-hydroxylase, there is no aldosterone, no cortisol. So, the whole pathway is now shunted towards the androgen synthesis. Now, there are lots and lots of androgens, and because of this lots and lots of androgens, now this female child is undergoing virilization. So, there will be development of ambiguous genitalia. Now, please concentrate, guys. Because of the absence of 21-hydroxylase, whenever there is no aldosterone, aldosterone production is getting decreased. Whenever there is no aldosterone, what happens? First of all, what is the normal function of aldosterone? Aldosterone helps in the sodium and water retention. Aldosterone helps in reabsorbing the sodium and reabsorbing the water. Whenever there is no aldosterone, salt is getting lost in the urine. So there is hyponatremia, salt is getting lost, and even there is water loss. Salt water wasting is seen, okay, because of the loss of aldosterone. Now, whenever the water is losing from the body and salt is losing from the body, this baby may have this hypotension. And one more function of aldosterone is aldosterone actually kicks out the potassium from the body. Okay, aldosterone kicks out the potassium from the body. So whenever there is decreased aldosterone, potassium will accumulate in the body, that will cause hyperkalemia. So what I am trying to put into your mind is congenital adrenal hyperplasia is not only a condition of ambiguous genitalia, but also a condition of electrolyte abnormalities, and these electrolyte abnormalities can even kill the baby. So important point is there is a variant, okay, there are variants of congenital adrenal hyperplasia, like a classical variant, salt losing variant. In salt losing variant, because of the loss of these electrolytes, the baby is at a risk of death. Okay, in a normal classical variant, there will be only simple ambiguous genitalia. If it is more severe form, that is a salt wasting form, where there is too much decrease in the aldosterone levels, there will be electrolyte abnormalities, and even this kill this baby. Okay, so that is the important point. Now let's see some other forms of congenital adrenal hypoplasia. Okay, before saying some other forms, okay, let's discuss all the important points. Okay, let's sum up all the important points. The karyotype is 46XX. It's a female. Yes. What are the ultrasonographic findings? If you do ultrasonography, this is a female, right? If it's a female, uterus, fallopian tubes, cervix are present, absolutely present. Uterus, cervix, fallopian tubes, ovaries, everything are normally present. Bar body is present. Females have bar body. Congenital adrenal hyperplasia is a condition of female pseudo hermaphroditism. See, this I will explain later. Okay, please keep this point in mind. This I will explain in the later slide. What are the clinical features? Because of this excess androgens, this female will have clitoromegaly. Here you can clearly see in this female child, there is this labial fusion and they are just looking like a scrotum. And the clitoris is enlarged and it just looking like a small penis. So I can say there is virilization in this female child. Okay, male child, too much androgens, not a problem. There might be precocious puberty in a male child, but female child, chance of virilization, chance of ambiguous genitalia. Okay, now the genital folds, they will fuse and form the penile urethra. The labia majora, they will fuse and they just looks like a scrotum. Okay, and because of the loss of mineralocorticoid, that is aldosterone, there can be this hyponatremia, hyperkalemia, hypotension. Okay, we have already seen those points. Now, what about the laboratory findings, guys? If it is the congenital adrenal hyperplasia, if you do the screening test for the 17-hydroxyprogesterone levels, the 17-hydroxyprogesterone levels are elevated more than 800 nanograms per deciliter. The diagnosis is established that this is congenital adrenal hyperplasia. Okay. Now, let's discuss about the treatment options for congenital adrenal hyperplasia. What we can do, guys, in this patient, in this female, there is this clitoromegaly and the labial fusion. So what we can do is take out this penis looking clitoris. So phallus should be removed and surgically we have to correct the vagina. So vaginoplasty should be done in this female child. Okay. Now guys, this female child is not having enough amount of mineralocorticoids and glucocorticoids. So what we should do? We should replace the mineralocorticoids and glucocorticoids. For the mineralocorticoid replacement, the drug which we are giving is a fludrocortisone. Okay, so to replace the aldosterone, we are giving the fludrocortisone, and to replace the glucocorticoid, that is cortisol, we are giving hydrocortisone. So for the treatment of congenital adrenal hyperplasia in a female, to replace glucocorticoids and mineralocorticoids, we are giving fludrocortisone and hydrocortisone. Now, the very important area in this slide is this. Okay, see, drug of choice for a female at the risk of having a baby with congenital adrenal hyperplasia. What does I mean by there is a woman, now she is pregnant. Previously, she had a baby with a congenital adrenal hyperplasia. Now she is worrying that the upcoming child, the new child, may also have congenital adrenal hyperplasia. So now, as a doctor, what you should do? You should prevent congenital adrenal hyperplasia and virilization in the upcoming child. Now the question is, if the upcoming child is a male, is there any problem? No. If the upcoming child is a female, that too unaffected, no problem. If the upcoming child is a female and if this female is affected means, then only it's a problem. So how we should know whether the child is a male, female unaffected or affected female? How we can know? We can know it by doing chorionic villus sampling by 10 to 13 weeks. But important point is that we are not going to perform chorionic villus sampling to know whether it's a male child, female unaffected or affected female. Why? Because chorionic villus sampling is done somewhere around 12 weeks. But by 12 weeks, already external genitalia are developed. Okay. See, even if it's a female child, because of excessive androgens, even a female child will undergo virilization and looks like a normal male child. So we are not going to depend on the chorionic villus sampling to know what is the sex of the child, and we are not going to do the treatment depend on the sex of the child. What we are doing immediately at the time of diagnosis of the new pregnancy, we are going to keep this female who are at a risk of giving birth to a female with congenital adrenal hyperplasia. We are going to keep her on dexamethasone. We are going to give dexamethasone to this mother. This dexamethasone is going to cross the placental barrier and enters into the fetal circulation, and this dexamethasone will suppress the ACTH production. So whenever there is no ACTH, there is no androgen production. Whenever there is no androgen production, there is no risk of virilization. So what we are doing to prevent virilization risk in the upcoming child, we are going to give dexamethasone to the mother. So this is the treatment. Drug of choice for a female who is at a risk of having a baby with congenital adrenal hyperplasia is dexamethasone. And when we have to give this dexamethasone, guys, after 12 weeks, after confirming the sex? No, immediately after putting the diagnosis of pregnancy. Okay, at the time of diagnosis of the pregnancy, you have to give the dexamethasone immediately. But it's better if you would have started before 9 weeks, not after 9 weeks. Okay, after 9 weeks there is no use. Why? Because already external genitalia are formed. Best is immediately after diagnosis of pregnancy, but not later than 9 weeks. Okay, not after 12 weeks. Now we have started this mother on dexamethasone. Okay, now what we are doing, we are going to perform chorionic villus sampling at 12 weeks. Okay, we will do chorionic villus sampling at 12 weeks. Now the result came that the growing baby is a male baby. Is there any problem? No. If it's a male fetus or if the growing baby is a female, that too it's an unaffected female. The genes are absolutely normal. Now if it's an unaffected female, then also not a problem. So what we can do? We can stop dexamethasone to the mother. Stop the steroids. If it is an unaffected female and male, stop the steroids. If it's a female fetus and that too if it's affected, what we can do? If it is an affected female, then what we can do is continue the dexamethasone throughout the pregnancy. Continue. Okay. So till the delivery, we have to keep this woman on dexamethasone. Okay. So this is the treatment, very, very important for the exams. In different exams, they will be asking you. Okay. I'm summing it up. In a normal female, okay, female with congenital adrenal hyperplasia, what's the treatment? Mineralocorticoid replacement fludrocortisone, glucocorticoid replacement hydrocortisone. But for the mother who is at risk of having a baby with CAH, it is dexamethasone. Immediately after diagnosis of pregnancy, that is urine pregnancy test is coming positive, immediately put her on dexamethasone. Okay, so this is the treatment, and we have to continue this treatment till the delivery. Okay, and even in this image, you can clearly see that there is this clitoromegaly and the labia are slightly fused. Now, please concentrate, guys. Let's see some different variants of congenital adrenal hyperplasia. Usually, congenital adrenal hyperplasia is going to affect the females, and that female will have features of virilization, ambiguous genitalia, and hypotension, salt wasting, hypokalemia. But there are certain variants of congenital adrenal hyperplasia where there is hypertension. How this is possible? Please concentrate. If there is a deficiency of this 11-beta hydroxylase, please concentrate. If there is deficiency of 11-beta hydroxylase, what happens? Again, there is congenital adrenal hyperplasia because there is no cortisol and no aldosterone. But please concentrate here. Whenever there is no 11-beta hydroxylase, the precursor products are going to accumulate. For example, in this condition, the 11-deoxycorticosterone, this one, as there is no 11-beta hydroxylase, this 11-deoxycorticosterone cannot be converted into corticosterone. So, these two products which are in this red color zone, they are going to be decreased. But what about the 11-deoxycorticosterone, guys? This 11-deoxycorticosterone is going to be elevated because it's not getting converted into corticosterone. Important point is that this 11-deoxycorticosterone can also act as a mineralocorticoid. It still have properties to act as just like a weaker version or milder version of the aldosterone. It's just like aldosterone is getting accumulated in the body. Okay, so this 11-deoxycorticosterone is getting elevated due to 11-beta hydroxylase deficiency. What happens if 11-deoxycorticosterone is getting building up in the body? It's just looking like aldosterone is building up in the body. If aldosterone is building up in the body, there is a salt and water retention. Okay, salt and water are getting reabsorbed back into the body. That causes hypertension. Salt in the body, hypertension. So, in this variant of congenital adrenal hyperplasia, there will be hypertension. 11-beta hydroxylase deficiency is going to present with hypertension and ambiguous genitalia. Okay, now let's see one more variant of congenital adrenal hyperplasia where there is a deficiency of 17-alpha hydroxylase. Important point is that 17-alpha hydroxylase, this enzyme is very important for the production of a cortisol pathway and androgen pathway. Okay, it's very clear, right? The cholesterol is getting converted into these pathways, these two pathways with the help of enzyme 17-hydroxylase. Whenever there is no 17-hydroxylase, again there is no cortisol and no androgens. Now please concentrate, very interesting. So this is a condition where there is no cortisol and no androgens. If there is no cortisol, it's very clear that there is no negative feedback on pituitary gland. Again, more ACTH, that more ACTH will cause adrenal hyperplasia. So, congenital adrenal hyperplasia. Okay. But here, if you see, not only cortisol is going down, androgens are also going down. The whole pathway is now shunted towards the production of aldosterone. So, in this variant of congenital adrenal hyperplasia where there is deficiency of 17-alpha hydroxylase, there are more amount of aldosterone in the body and less amount of cortisol and less amount of dihydrotestosterone. Now, whenever there are no testosterone, what happens? Now think, this is a male child. Now, imagine that this variant of congenital adrenal hyperplasia is happening in a male fetus, for example. Now, in a male fetus, there are no androgens. Whenever there are no androgens in a male developing embryo or male developing fetus, what happens? The external genitalia will become female like. Yes, for the development of male external genitalia, you need to have androgens. Whenever the androgens are going down in 17 alpha hydroxylase deficiency, the male will again develop a female external genitalia. So what I am trying to put into your mind is that congenital adrenal hyperplasia classically is going to affect female fetuses, and female fetuses will have this virilization, normal 21 hydroxylase deficiency forms. There are certain forms of congenital adrenal hyperplasia like 17 alpha hydroxylase deficiency where a male fetus can be affected, and this male fetus can develop feminized or complete female external genitalia. Okay, and even in this form, because of the increased aldosterone, there will be hypertension and hypokalemia. Aldosterone will kick out the potassium from the body, that causes hypokalemia. Okay, so this is all about the congenital adrenal hyperplasia. Now let's see some images how it looks like. See, here there is clitoromegaly because of the excessive amount of androgens in the classical form, 21 hydroxylase deficiency form. There is clitoromegaly and this labia are slightly fused. Okay, it just looks like ambiguous, whether it's a male or female, very much ambiguous. And even here there is a clitoromegaly and labial fusion. Okay, now even in these images you can see there is a clitoromegaly. Here it's very much like a micro small penis. Okay, there is a very much clitoromegaly, just looking like this is the glans penis and this is small penis. Okay, so congenital adrenal hyperplasia is a condition which causes ambiguous genitalia. A female looks like a male at the time of birth, and like the doctors are confused to announce to the parents that whether it's a male child or a female child. Ambiguous genitalia is seen. Okay, now let's see some cases about congenital adrenal hyperplasia. A newborn was born and found to have clitoral enlargement and labia fusion. What is the first step in coming to the diagnosis? Guys, what they are saying, there is this clitoral enlargement and labial fusion. Clitoral enlargement and labial fusion means nothing but ambiguous genitalia. Now, this is a newborn. See, after this newborn was born, you have to announce to the parents about what kind of baby they had, whether it's a male or female. Now you are in a dilemma that whether this baby is a male or female, because this baby is having this ambiguous genitalia. So now what you have to do? You are supposed to announce to the parents, but here there is this ambiguous genitalia. To confirm whether this is a male or female, the first step, remember, in ambiguous genitalia, the first step to do is karyotyping. Without any doubt, if there are this ambiguous genitalia, the first thing to be done is karyotyping. Okay. After this, let's see one more case. A newborn was born and found to have clitoral enlargement and labial fusion. Karyotypy is done, and the karyotypic studies came XX. It's a female, very much clear. The karyotype is XX, and the external genitalia is showing ambiguity because of clitoral enlargement and labial fusion. Okay, now you are thinking about, see, the diagnosis already came into your mind that, okay, a female with ambiguous genitalia is mostly going to be a case of congenital adrenal hyperplasia. But what is the next step to be done? Based on the options, let's derive. Karyotypy? No. Why to do karyotypy? Why? Because already karyotypy is done. It came XX. serum testosterone, pelvic ultrasound, 17 hydroxyprogesterone levels. Now tell me, see, in the background, you are having an idea that this is congenital adrenal hyperplasia. To diagnose that, what you will do? Now, first check the 17 hydroxyprogesterone levels. Why? Because we know in the condition of congenital adrenal hyperplasia, the 17 hydroxyprogesterones will be damn elevated, so much elevated, 800 nanograms per deciliter, even more than that. So, the better option here would be 17 hydroxyprogesterone levels. Okay. Now, let's see one more case. A 3-year-old child found to have clitoral enlargement and labial fusion. Karyotypy shows XX and serum hydroxyprogesterone levels are elevated. Very clear. Female karyotype, clitoral enlargement and labial fusion, which means ambiguous genitalia, and even the 17 hydroxyprogesterone levels are elevated, which is very clear that this is a case of congenital adrenal hyperplasia. What is the most appropriate treatment? How to treat a child or how to treat this female who is having congenital adrenal hyperplasia? What we can do? For the replacement of mineralocorticoid, you can give fludrocortisone. For the replacement of glucocorticoid, you can give hydrocortisone. Okay, so salt-rich diet, not appropriate treatment. See, salt can be given because the salt wasting, right? Salt diet can be given, but that's not the only thing. The main important thing is giving fludrocortisone and hydrocortisone. Okay, so treatment with the glucocorticoids. Yes, treatment with the glucocorticoids. Give this female, okay, give this female glucocorticoids, and these glucocorticoids, especially the cortisol, these glucocorticoids will go into her body, and these glucocorticoids will give the negative feedback to her pituitary gland. So the pituitary gland is not making the ACTH. The glucocorticoid which we are going to give is hydrocortisone. Okay, the mineralocorticoid replacement is fludrocortisone. That anyway is not given in the option. Treatment with the estrogens, no, we are not going to do that. And vaginoplasty, see, vaginoplasty can be done even in the later half. Okay, even in the later life, vaginoplasty can be done. See, you have to remove that, phallus or the clitoromegaly, you have to remove that, and vaginoplasty should be done. That is something we are going to do in the later life. But now, to prevent this child from mortality, because there are these electrolyte abnormalities, we have to replace the mineralocorticoids and glucocorticoids. Okay, so that thing is very much important. After this, let's continue with the other question. Woman present to the antenatal clinic, she had her last menstrual period 6 weeks ago. Okay, last menstrual period 6 weeks ago. Urine pregnancy test came positive. She had, this is important, she had a history of a previous child with a congenital adrenal hyperplasia. Now this mother, she is worrying because she is having a baby, female baby with a congenital adrenal hyperplasia previously. Now she is worrying about the current pregnancy, that even this baby might have congenital adrenal hyperplasia. So how to prevent congenital adrenal hyperplasia in the upcoming child? We all know, keep this woman on dexamethasone. This dexamethasone crosses the placental barrier and enters into the fetal circulation and suppresses the ACTH. So the best option is immediate treatment with dexamethasone. Okay, this is the better option. Okay, after this, let's talk about the true versus pseudo hermaphroditism, which is very important. Now, please concentrate what exactly is meant by true hermaphrodite. True hermaphrodite means karyotypically both male and female karyotype is present. Okay, both male karyotype, that is 46XY, and female karyotype 46XX, both are present. Gonads show ovotestis, which means ovaries on one side, testes on other side. Both ovarian tissue are in a combined, both ovarian tissue and testicular tissue is present, which is known as the ovotestis. Okay, So gonads are both ovo-testis. And what about the external genitalia? External genitalia will be also a fusion of both the male and female. Down here in this image, you can clearly see that there is a female-like genitalia and a male-like genitalia. So both external genitalia is male and female. Karyotypy is also male and female. The functional gonads, these functional gonads are ovo-testis. Okay, so this is what is known as a true hermaphrodite. True hermaphrodite is a condition with both male and female internal reproductive functional gonads. Okay, now what about pseudo hermaphrodite? We have already discussed. What exactly is meant by a pseudo hermaphrodite? Pseudo hermaphrodite means karyotypically male, means the genes are male, the chromosomes are male. Okay, karyotypic male, but phenotypically looking like a female, a male looking like female. Are you getting? Can you able to recall something? A male looking like a female, androgen insensitivity syndrome, testicular feminization syndrome. Okay, so that condition is known as a male pseudo hermaphroditism. A male looks like a female is known as a male pseudo hermaphroditism, and the example is, most common example is androgen insensitivity syndrome. They can ask you, what's the most common cause of male pseudo hermaphroditism? It is AIS. And what does it mean by female pseudo hermaphroditism? Female pseudo hermaphroditism means a female, karyotypic female, which means absolutely a female, looks like a male. Are you able to recall that condition, which is known as congenital adrenal hyperplasia? Okay, so if a female looks like a male, it's not a combination of both male and female. A combination of both male and female internal reproductive organs, that's the ovo-testis, is known as a true hermaphrodite. Pseudo hermaphrodites are a male looks like a female, female looks like a male. Okay, so if a female is looking like a male, then it is known as a female pseudo hermaphroditism, and the most common cause for female pseudo hermaphroditism is congenital adrenal hyperplasia. We have discussed. Now, after this, let's see a few important points. Okay, other causes for ambiguous genitalia in a female. See, what is the most common cause for ambiguous genitalia in a female? That's a congenital adrenal hyperplasia, where there are too much amount of androgens, and those too much amount of adrenal androgens are causing virilization in a female child, that we have already discussed. But there are certain other conditions like aromatase enzyme deficiency. Okay, imagine that in a female, if aromatase is not there, what aromatase will do? Aromatase is the enzyme converting androgens into estrogens. Okay, aromatase is the enzyme converting androgens into estrogens. If in a female this aromatase is not there, means peripheral aromatization, conversion of androgens into estrogens is not happening. So there is no estrogens, and androgens will accumulate in this female body, and these androgens will cause virilization, so that the female will develop male looking genitalia, ambiguous genitalia. So aromatase deficiency will cause that. And maternal androgen drug excess. See, mother is there and now she is pregnant. Okay, there is a pregnant lady and she is carrying a female fetus. Now, there is this female growing inside her womb. Now, mother is taking excessive androgenic drugs, and these drugs are crossing the placenta and entering into this female fetus. And in this female fetus, they are causing virilization, leading to ambiguous genitalia. Okay, that thing. And pregnancy luteoma. There is this pregnancy luteoma in the mother. This pregnancy luteoma is going to produce lots and lots of androgens, and these lots of androgens is going to enter into the fetal circulation, and in the fetus, these androgens, maternal androgens, are going to cause virilization and ambiguous genitalia. So these are certain conditions which are associated with ambiguous genitalia in a female. Okay, so we have discussed the important differences between true hermaphroditism and pseudo hermaphroditism. Again, I am repeating, true hermaphrodite is a condition where there is combination or amalgamation of both the sexes, ovaries, testis, ovo, testis, and both of them are functional, and the external genitalia is also a combination of both. Okay, both male and female looking genitalia. Okay, now after this, let's talk about a very small topic, which is a mixed gonadal dysgenesis. Gonadal dysgenesis we have completed. Gonadal dysgenesis in a male leads to Swyer syndrome. Gonadal dysgenesis in a female we have discussed, that's a Turner syndrome. Both of them are completed. Now mixed gonadal dysgenesis, what does I mean by? See, there is a condition where the person have both the gonads, just like a true hermaphroditism. The person have this both ovo testis and both of them are non-functional. See, if both the ovo testis are functional, then the person is going to have both male and female looking genitalia. Now the condition is mixed gonadal dysgenesis. In the condition of a mixed gonadal dysgenesis, the person have both male and female gonads, but both of them are non-functional. If both the male and female gonads are non-functional, means what happens? Just think, ovaries are there, testes are there, both of them are non-functional. So, if both of them are non-functional, there is no estrogen and there is no testosterone. If no estrogen, no testosterone, what will be the external genitalia? There is nothing to do with the estrogens. Estrogens doesn't have any important role in making the external genitalia. It's all about the testosterone and dihydrotestosterone, which makes the external genitalia as a male. Now, in this condition, if there is no testosterone, what happens? By default, the external genitalia will become female-like. So, mixed gonadal dysgenesis is a condition where the karyotype is of both the sexes, both male and female karyotype is there. And gonads, both male and female gonads are there. But they are non-functional gonads. So, what happens? The external genitalia will become female-like. Okay, so important point is that in mixed gonadal dysgenesis, the external genitalia is female. In pure gonadal dysgenesis, for example, Swyer syndrome, pure gonadal dysgenesis, there also the external genitalia is female. So in pure gonadal dysgenesis, the external genitalia is female. Even in Turner, the external genitalia is female. Even in mixed gonadal dysgenesis, the external genitalia is female. Okay, but in true hermaphroditism, the external genitalia is a combination of both the sexes. Okay, now most of the people think the mixed gonadal dysgenesis and true hermaphroditism, they are one and the same. No, please concentrate. In true hermaphroditism, the external genitalia is a combination of both. But in mixed gonadal dysgenesis, the external genitalia is absolutely female. In true hermaphroditism, the gonads are ovo testis, which are functional. In mixed gonadal dysgenesis, both the male and female gonads are non-functional. Okay, so there is a lot of difference between these two conditions. Now, let's talk about Klinefelter syndrome. I don't find any other place to discuss about the Klinefelter syndrome because already we have discussed the Turner syndrome, which is a monosomy X. Now, let's discuss about the Klinefelter syndrome. Klinefelter is a condition where there is an extra X. Okay, there is 47 double XY. Instead of 46 chromosomes, there is 47 chromosomes, and that extra chromosome is nothing but the X chromosome. Okay, normally male is XY, but there is an extra X. Usually X is something for the female, Y is something for the male. Okay, now having this extra X makes this male a more female-like. Okay, see, because of this presence of extra X, there is this gynecomastia, okay, breast development in the male. Not all the males will have this. Some males with Klinefelter syndrome will present with the gynecomastia, okay. Now, what about the Turner syndrome? Because of the loss of X chromosome, the females are short. Now, in this condition, there is an extra X. So, Klinefelter males are tall. Okay, they will have tall stature. Karyotype is 47 XY. They might have this gynecomastia. Because of the presence of this extra X chromosome, which is something a more a female thing, the male functions are not going to happen properly. What does I mean by? Because of the presence of this extra X, there will be azoospermia and infertility. Because of this azoospermia, the male can have infertility. The important point is that Turner female is having normal intelligence. She is having a normal IQ. But a person with a Klinefelter syndrome will be present with a mental retardation. Okay, so these are some important points about the Klinefelter syndrome. Again, the same Klinefelter syndrome will be discussed in the topic of male infertility. But for now, this is enough. I have completed all the different types of intersex. Hope the video is helpful. Thank you.